Welcome to another episode from the Veterinary Medicine Digest. Today, we embark on a journey into the intricate and vital relationship between the hypothalamus and the pituitary gland, exploring how this foundational partnership governs metabolic health and how its disruption, often by tumors, challenges veterinary medicine. The master control, anatomy and hormonal orchestration. The pituitary gland, historically known as the hypophysis, is a tiny but essential structure, typically measuring about 1 centimeter in diameter and weighing less than a gram, residing within the sella turcica, a bony depression at the base of the brain. It is connected directly to the master conductor, the hypothalamus, by the hypophyseal stalk. Physiologically, the pituitary is divided into two principal parts: the anterior pituitary, or adenohypophysis, and the posterior pituitary, or neurohypophysis. An intermediate zone, the pars intermedia, exists between them, which is small in humans but significantly more developed and functional in some lower animals. These two main sections have distinct embryological origins, underscoring their functional differences. The anterior pituitary originates from an embryonic outpouching of the pharyngeal epithelium known as Rathke's pouch, which accounts for the epithelial nature of its hormone-producing cells. In contrast, the posterior pituitary develops from a neural tissue outgrowth from the hypothalamus, explaining the presence of glial-type supporting cells within it. The hypothalamus exerts almost complete control over pituitary secretion through both hormonal and nervous pathways. If the pituitary gland is transplanted away from the hypothalamus, the secretion rates of most of its hormones, excluding prolactin, drop severely. Control over the anterior pituitary is achieved through hypothalamic releasing and inhibitory hormones. These critical regulatory hormones are synthesized by specialized neurons in the hypothalamus and secreted into the median eminence and tuber cinereum. They travel to the anterior pituitary through a minute network of vessels known as the hypothalamic hypophyseal portal vessels, which carry the hormones directly to the glandular cells to control their secretion. Control over the posterior pituitary is simpler and relies directly on nerve signals originating in the hypothalamus and terminating within the posterior lobe itself. The hypothalamus acts as a central collecting center, integrating a vast array of information concerning the body's internal status. It processes signals relating to pain, emotional excitement, trauma, olfactory stimuli, and the concentrations of nutrients, electrolytes, water, and various circulating hormones in the blood. This comprehensive feedback allows the hypothalamus to precisely adjust the secretion rates of the globally important pituitary hormones. The anterior pituitary is a factory for 6 major peptide hormones vital for regulating metabolism throughout the body. These hormones are produced by specialized cell types, somatotropes, comprising 30 to 40% of the anterior pituitary cells and categorized as acidophils because they stain strongly with acid dyes, secrete growth hormone, or somatotropin, which promotes overall body growth by stimulating protein formation, cell multiplication, and differentiation. Corticotropes, about 20% of the cells, secrete adrenocorticotropin, or corticotropin, which regulates the production of adrenocortical hormones essential for glucose, protein, and fat metabolism. Thyrotropes secrete thyroid-stimulating hormone, or thyrotrophin, controlling the thyroid gland's output, which in turn regulates most intracellular chemical reactions. Lactotropes produce prolactin, necessary for mammary gland development and milk secretion. Lastly, gonadotropes produce 2 hormones, follicle-stimulating hormone and luteinizing hormone, which manage the growth and reproductive functions of the ovaries and testes. The hypothalamic hormones that specifically control these secretions include thyrotropin-releasing hormone, which releases thyroid-stimulating hormone, corticotropin-releasing hormone, which releases adrenocorticotropin, and gonadotropin-releasing hormone, which releases the 2 gonadotropic hormones. For growth hormone, 2 counterregulatory peptides are involved. Growth hormone, releasing hormone promotes release, while growth hormone inhibitory hormone, or somatostatin, suppresses release. Prolactin secretion is primarily restrained by prolactin inhibitory hormone, which is dopamine. The 2 hormones secreted by the posterior pituitary are antidiuretic hormone, also known as vasopressin, and oxytocin. Antidiuretic hormone regulates water excretion in the urine to maintain fluid concentration in the body. Oxytocin promotes milk ejection during suckling and assists in labor. These hormones are not made in the pituitary itself, but are synthesized in the magnocellular neurons located in the supraoptic and paraventricular nuclei of the hypothalamus. They are then transported down the nerve fibers, the hypothalamic hypophyseal tract. In combination with carrier proteins called neurophysins, finally being secreted from bulbous nerve endings located directly on capillaries in the posterior pituitary. The hypothalamic pituitary-adrenal axis, a deep dive into metabolic stress. The hypothalamic pituitary-adrenal axis, or HPA axis, is the system governing stress response and glucocorticoid production. This axis is initiated in the hypothalamus, where corticotropin-releasing hormone stimulates adrenocorticotropic hormone secretion from the anterior pituitary, pars distalis. The adrenocorticotropic hormone then causes the adrenal glands to secrete glucocorticoids. Crucially, these glucocorticoids enforce a negative feedback loop, suppressing further secretion of both adrenocorticotropic hormone by the pituitary and corticotropin-releasing hormone by the hypothalamus. The function of the HPA axis is essential during metabolic stress, such as fasting, which initiates numerous adaptations for survival. The resulting activation of the HPA axis mobilizes fuel stores to meet energy demands, particularly by increasing blood glucocorticoid hormones, which in rodents is corticosterone. Glucocorticoids maintain glucose homeostasis by directly stimulating gluconeogenesis in the liver, mobilizing gluconeogenic precursors from muscle protein, and promoting lipolysis in adipocytes, which spares limited glucose for the brain. This vital response appears to be triggered by a fall in the adipose tissue-derived hormone leptin, as fasting lowers leptin levels. Scientists hypothesize that agouti-related peptide-expressing neurons, known as AGRP neurons, which are activated by fasting and leptin deficiency, drive this HPA axis activation. Research confirms that increased AGRP neuron activity is vitally important for driving corticosterone release during fasting. The precise mechanism involves AGRP neurons projecting to the paraventricular hypothalamus, PVH, which is the functional apex of the HPA axis containing the corticotropin-releasing hormone-expressing neurons. AGRP neurons typically release inhibitory neurotransmitters, gamma-aminobutyric acid, neuropeptide Y, and AGRP. They cannot activate the HPA axis via direct excitation of the corticotropin-releasing hormone neurons. Instead, they employ a sophisticated and indirect method known as presynaptic disinhibition. The key discovery is that AGRP neurons specifically target tonically active inhibitory afferents originating from the bed nucleus of the stria terminalis, BNST, that constantly restrain the excitability of corticotropin-releasing hormone neurons. When AGRP neurons are activated, they release gamma-aminobutyric acid and neuropeptide Y into the paraventricular hypothalamus, where these neurotransmitters act on gamma-aminobutyric acid type B receptors and neuropeptide Y receptors located on the terminals of these inhibitory BNST neurons. This action causes presynaptic inhibition of gamma-aminobutyric acid release from the BNST terminals, thereby reducing the inhibitory tone onto the corticotropin-releasing hormone neurons. The resulting disinhibition potently activates the corticotropin-releasing hormone neurons and drives the HPA axis. Inhibition studies suggest that gamma-aminobutyric acid acting on gamma-aminobutyric acid type B receptors plays a more prominent role in this disinhibition than neuropeptide Y. However, the presence of redundancy between gamma-aminobutyric acid and neuropeptide Y demonstrates the importance of preserving this vital adaptive response to fasting. Furthermore, this action of AGRP neurons to activate the HPA axis is a distinct function that operates in parallel to and independently of their other well-known role in stimulating hunger and feeding behavior. Pituitary macrotumors and hyperadrenocorticism in dogs. When control of the HPA axis is lost, the most common consequence in dogs is hyperadrenocorticism, or Cushing's syndrome. This is attributed to functional pituitary tumors in 80 to 85% of naturally occurring cases, known as pituitary-dependent hypercortisolism, PDH. This excessive, autonomous secretion of adrenocorticotropic hormone causes the bilateral enlargement, or hyperplasia, of the adrenal cortex and chronic overproduction of glucocorticoids. Pituitary tumors are the most common tumors of the sella turcica, often occurring in middle-aged and geriatric dogs. Pituitary tumors are typically classified based on size, though definitions are somewhat inconsistent in veterinary medicine due to variable canine conformation. Historically, classification was based on human medicine. Microadenomas are usually less than 10 mm in diameter, and macroadenomas are greater than 10 mm. A more accurate method to account for varying canine conformation involves using the pituitary height to brain area ratio. A ratio of greater than or equal to 0.4 times 10 to the negative 2 power inverse millimeters is typically used to define a macrotumor. The actual incidence of pituitary macrotumors in dogs with pituitary-dependent hypercortisolism is difficult to determine because advanced imaging is not routine, but estimates vary widely from 15% to possibly 75% when all visible masses are considered. In a recent study focusing on dogs undergoing pituitary evaluation, 41.5% of dogs with pituitary-dependent hypercortisolism were classified as having macrotumors. Most pituitary tumors seen are adenomas, though invasive adenomas and carcinomas are rare. Pituitary tumors that secrete large amounts of growth hormone are often called acidophilic tumors due to the staining properties of the somatotrope cells they originate from. The underlying cause of these adrenocorticotropic hormone-producing pituitary tumors, or corticotrophinomas, is subject to debate. The hypothalamic theory suggests excessive stimulation of corticotrophs via increased corticotropin-releasing hormone from the hypothalamus, coupled with defective pituitary glucocorticoid receptors leading to reduced inhibitory action of cortisol. Conversely, the pituitary theory is supported by findings of tumor clonality in human adenomas, suggesting a primary pituitary origin. The observation that medically reducing cortisol secretion with drugs like trilostane results in reduced negative feedback, which in turn leads to pituitary gland enlargement in healthy dogs, supports the role of negative feedback regulation in disease progression. Clinical manifestations and risk factors. The clinical signs of hyperadrenocorticism result from the catabolic, gluconeogenic, and immunosuppressive effects of chronic excessive glucocorticoid hormones. The most consistently reported clinical signs include polyuria and polydipsia, affecting 82 to 91% of cases, likely due to cortisol-induced decreased vasopressin secretion or decreased renal sensitivity to vasopressin. Other common signs are polyphagia, 46 to 57%, abdominal enlargement, 67 to 73%, due to hepatomegaly, fat accumulation, and muscle wasting, and alopecia, up to 74%, due to follicular atrophy. Calcinosis cutis is considered a pathognomonic sign, although rare. Hypercortisolism is frequently associated with serious comorbidities. Between 10.5 and 13.6% of dogs with hyperadrenocorticism are concurrently diagnosed with diabetes mellitus due to insulin resistance caused by cortisol excess. The prevalence of gallbladder mucocole is reported between 1.6 and 23% in dogs with hyperadrenocorticism. Furthermore, hyperadrenocorticism leads to a hypercoagulable state, which may result in pulmonary thromboembolism, identified in 2.7% of necropsy cases. The primary danger of a pituitary macrotumor is the mass effect it exerts on adjacent neural structures. Neurological abnormalities occur in 10 to 30% of dogs with pituitary-dependent hypercortisolism, signaling disruption of the thalamic, hypothalamic, or optic chiasm function. The anatomical configuration in dogs typically favors dorsal expansion, leading to diencephalon and hypothalamic compression, rather than immediate pressure on the optic chiasm leading to blindness, which is more common in humans. Highly associated neurological signs in dogs with macrotumors include depressed mental state, seizures, staggering, wandering, and circling. Dogs with larger tumors may also exhibit lower body temperature and heart rate, reflecting autonomic dysfunction possibly due to hypothalamic compression, though this finding is not consistently significant in all studies. Identifying risk factors is paramount for determining which patients require costly and specialized advanced imaging. Recent multivariate analysis identified 3 significant risk factors for pituitary macrotumor in dogs with hypercortisolism. 1. French Bulldog breed. French Bulldogs showed an immensely high risk, with an odds ratio of 21.0. This breed predisposition may be linked to their brachycephalic skull structure, which could restrict compensatory mechanisms against increased intracranial pressure, leading to earlier clinical symptom manifestation. 2. Presence of neurologic signs. The occurrence of any neurological signs was strongly correlated with macrotumors, demonstrating an odds ratio of 10.9. Specific signs such as depressed mentation and seizures were found to be significantly more common in the macrotumor group. 3. Younger age at diagnosis. Dogs diagnosed with hypercortisolism at less than or equal to 10.9 years of age were significantly more likely to have a macrotumor. Acromegaly, excess growth hormone. Another endocrinopathy stemming from pituitary dysfunction is acromegaly, or hypersomatotropism, characterized by the elevated production and secretion of growth hormone. The pathogenesis of acromegaly varies significantly between dogs and cats. In adult and aged cats, acromegaly is usually linked to functional pituitary macroadenomas derived from somatotropic cells, resulting in hormonal overproduction. In dogs, however, acromegaly is typically related to elevated serum progesterone levels, often occurring during the luteal phase of the estrous cycle in unspayed females or following the administration of exogenous progestogens. This progesterone stimulates the mammary glands to produce and secrete growth hormone. The extended period of high progesterone exposure during the canine reproductive phase of diestrus can lead to excessive circulating growth hormone and resulting acromegaly. Growth hormone exerts both catabolic and anabolic effects. The catabolic activity promotes insulin resistance, frequently leading to concurrent diabetes mellitus. The anabolic effects are mediated primarily by insulin-like growth factor 1, also called somatomedin C, which is produced by the liver in response to growth hormone stimulation. This factor drives the proliferation of bone, cartilaginous tissue, and soft tissues, leading to organ enlargement. Clinical signs reflect both the anabolic changes and the associated insulin resistance. Morphological changes are prominent, including enlargement of the face and extremities, cutaneous thickening, and prognathism, protrusion of the jaw. Animals may also show increased thirst and urination, polyuria and polydipsia, increased hunger, polyphagia, weight gain, and macroglossia, enlarged tongue. In cats, the pituitary macroadenoma can cause central nervous system compression, leading to neurological signs like sensory ataxia, tetraparesis, and plantigrade locomotion, even without concurrent diabetes mellitus. Diagnosis involves evaluating clinical signs and imaging alongside the measurement of growth hormone and insulin-like growth factor 1 concentrations. Values exceeding 1,000 nanograms per milliliter for the latter are strongly suggestive of substantial acromegaly. Therapeutic strategies for pituitary tumors. The management of pituitary tumors requires a multifaceted approach, utilizing surgery, radiation, and pharmacotherapy tailored to the specific hormonal imbalance and tumor burden. Surgical management. Transsphenoidal hypophysectomy, the surgical removal of the pituitary gland, is a curative treatment recommended for acromegaly of pituitary origin and pituitary-dependent hypercortisolism. Success rates are high, with reported remission rates for pituitary-dependent hypercortisolism in dogs averaging 82%, and a good 1-year estimated relapse-free fraction. However, the procedure is complex, requires significant expertise, and is limited by potential complications such as temporary decreased tear production, hyponatremia, and permanent diabetes insipidus. Surgical removal can be challenging when the tumors are large macroadenomas. Radiation therapy. Radiation therapy is increasingly common, offering a non-invasive option particularly effective for neurological signs caused by the tumor mass effect. Radiation therapy has shown efficacy in decreasing tumor size and extending survival time significantly compared to medical management, or no treatment. A recent large study comparing outcomes of 94 dogs treated with radiation therapy found that the distinction between dogs with pituitary-dependent hypercortisolism and those with non-hormonally active pituitary masses did not result in a statistically significant difference in survival time. Median survival times were similar between the pituitary-dependent hypercortisolism group and the non-pituitary-dependent hypercortisolism group. However, the type of radiation protocol did significantly impact survival. Definitive radiation protocols, which deliver a higher total radiation dose, resulted in a median survival time of 605 days, which was significantly longer than the median survival time of 262 days seen with palliative protocols. Multivariate analysis determined that the total radiation dose delivered in gray was the only factor statistically associated with longer survival. Despite its efficacy in tumor shrinkage, radiation therapy's effect on consistently reducing excessive hormonal secretion is often inconsistent across studies. Medical management. For pituitary-dependent hypercortisolism, traditional adrenal-directed treatments include trilostane, inhibits cortisol production, and mitotane, adrenolitics. A critical concern with these treatments is the potential acceleration of pituitary tumor growth due to the loss of glucocorticoid negative feedback on the hypothalamus-pituitary-adrenal axis. This phenomenon, known as Nelson syndrome in humans following bilateral adrenalectomy, is a major consideration because the loss of inhibitory cortisol feedback may stimulate corticotrophs to increase adrenocorticotropic hormone secretion and promote tumor enlargement. A novel pituitary-directed approach involves pasireotide, a multi-receptor somatostatin analog with high affinity for somatostatin receptor subtypes, particularly subtype 2, which is highly expressed in canine corticotroph adenomas. Pasireotide works by directly inhibiting adrenocorticotropic hormone secretion from the pituitary gland. A study evaluating the safety and effect of adding pasireotide to existing adrenal-directed treatments, trilostane or midostane, in dogs with pituitary-dependent hypercortisolism and macroadenomas showed that 2/3 of the dogs experienced a decrease in pituitary tumor volume after 6 months of combined treatment. Importantly, no dog developed new neurological abnormalities or signs of adverse effects during the treatment period. This suggests that the combined use of pasireotide may mitigate the risk of pituitary tumor expansion associated with reduced negative feedback, although further prospective studies are needed to confirm this anti-progression effect. For acromegaly, in dogs, acromegaly induced by progesterone is managed by removing the hormonal stimulus, either through the progesterone antagonist aglapristone, to promote premature luteolysis, or by ovariohysterectomy. If mammary tumors are the source of growth hormone, their complete removal is recommended. For pituitary-driven acromegaly in cats, medical options often include somatostatin analogs, such as octreotide. However, newer drugs like pasireotide have proven useful in cats refractory to older analogs because pasireotide targets multiple receptor subtypes. Dopaminergic agonists such as cabergoline or selegiline may also be used, though they often exhibit lower efficiency compared to somatostatin analogs. Concomitant pituitary-related conditions. The interdependence of the endocrine system means pituitary or hypothalamic pathologies rarely occur in isolation. Centropituitary hypothyroidism, secondary hypothyroidism, resulting from a loss of pituitary thyroid-stimulating hormone secretion, is uncommon but can be caused by conditions resulting in hypercortisolemia. Chronic hypercortisolism reduces thyrotrophin-releasing hormone gene expression in the hypothalamic paraventricular nucleus and increases somatostatin release, both of which inhibit thyroid-stimulating hormone secretion. While central hypothyroidism is typically associated with expanding pituitary tumors in veterinary reports, a complex case was documented in a miniature schnauzer with non-adrenal dependent hyperadrenocorticism and central pituitary hypothyroidism without an identifiable macroadenoma on high-resolution imaging. This highlights that even in the absence of a large, visible mass, the hormonal environment created by hypercortisolism can suppress the hypothalamic pituitary thyroid axis, complicating diagnosis and requiring careful monitoring and tailored treatment protocols for both conditions. The management priority in such cases is often controlling the hypercortisolism first, due to its axis-suppressing effect. The complex interplay between the hypothalamus and the pituitary dictates the metabolic stability of the entire body. When this axis is disturbed by proliferative lesions, the resulting hormonal imbalances necessitate precise diagnostic tools and advanced therapeutic techniques, offering patients an increasingly positive prognosis through methods such as surgery, focused radiation therapy, and sophisticated receptor-targeting medications. The detailed understanding of neural circuitry, from the macroanatomical views to the micro-level disinhibition mechanisms of the HPA axis, is continuously advancing the management of these challenging endocrine diseases. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,